Epidemiology of Visual Impairment. We'll be exploring 4 learning objectives in this presentation. We'll define the epidemiology of blindness and visual impairment, and describe the main causes of blindness globally. We'll then go on to explore the trends and socioeconomic variations in blindness, both globally and within a population, before finally we relate epidemiological information on visual impairment to person, place and time. There are 4 aspects to the epidemiology of visual impairment: magnitude, how many people are affected; distribution, where is the visual impairment; determinants, what are the main causes; and control, what can we do about it. We can use these factors to determine appropriate public health control measures. Magnitude of visual impairment. The definition of a case in visual impairment is based on the World Health Organization's classification. The magnitude of visual impairment worldwide is currently estimated to be about 285 million people. Of these, 39 million people are blind and 246 million have low vision. Why is it important to define visual impairment? Well, if our case definition changes, then the numbers change too. For example, if we define blindness as a best corrected visual acuity in the better eye of less than 360, we can estimate that there are about 37 million blind people globally. If presenting vision in the better eye is used instead, then the number of blind people increases to 45 million. And if we define blindness as a presenting visual acuity in the better eye of less than 660, then the estimate increases again, this time to 75 million blind people. In 1996, it was estimated that there were 45 million blind people in the world. Using predictions of global population growth and population aging, it was calculated that this number would rise to 76 million blind people by 2020 if service provision levels did not change. Recent data from 2010 shows that there has been a decline in the numbers of blind people globally, following the Vision 2020 Right to Sight intervention. Distribution of visual impairment. When we compare the distribution of visual impairment across the world, we find that it is unevenly distributed, with 90% of it in low and middle income countries. Estimated prevalences are shown as low, medium and high to provide a broad comparison across the various regions. Prevalence data is important. It allows health workers to identify the number of blind and visually impaired people in their country or region. This graph shows the numbers of blind people in each World Health Organization region. You can see how the burden of blindness varies by region, and that it is closely linked with the strength of economy and available health care. Very poor economies have a prevalence of blindness of more than 1%. This translates to more than 10,000 blind people per million population. In strong economies, prevalence of blindness is about 0.25%, or 2,500 blind people per million population. Africa, which has about 11% of the world's population, has a disproportionately high number of blind people, about 6 million, compared to China, which has 20% of the world's population, and about 8 million blind people. The distribution of visual impairment is affected by age. Globally, 82% of all blind people are aged 50 years and over. The importance of childhood blindness is not in the numbers affected, but in the number of years a child has to live with that blindness. This is sometimes referred to as blind years. Distribution of blindness is affected by gender. Most surveys around the world have found more blind women than men. A study in 2001 estimated the gender distribution of global blindness as 64% women and 36% men. The main reasons for this are: there are more women than men over the age of 50 in most populations. Women often do not have equal access to eye care services. And women are at a higher risk of blindness from certain conditions, for example trachoma. Causes of visual impairment. Global data has identified that refractive errors and cataract cause over 75% of all visual impairment in the world. These two diseases occur across all populations and are closely linked with aging. Other causes of visual impairment, such as trachoma, corneal opacities and childhood blindness, occur among specific at-risk populations. Diabetic retinopathy, glaucoma and age-related macular degeneration are diseases that are on the increase globally. Finally, it is difficult to identify a single main cause for about 18% of visual impairment. Causes of blindness. Globally, cataract is the main treatable cause of blindness, as we have a relatively simple and effective surgical treatment for it. Causes of blindness vary across economies. Cataract is a major cause of blindness in Africa, whereas in Europe, age-related macular degeneration is a bigger problem. Risk of blindness is closely linked to poverty. Very poor individuals and communities are at the highest risk of blindness. Poor communities are also at more risk from treatable and preventable causes of blindness. To address this issue, it is important that eye care services are accessible by all. Individuals in poor economies often have poor nutrition and lack access to sanitation and hygiene. This increases their risk of eye infection. They also have an increased risk of ocular trauma. This larger need for eye care in poor economies is often poorly supported by a weak health system, and this increases reliance on traditional medicine. A key global risk factor for visual impairment is increasing growth in the world's population. In 1960, the global population was approximately 3 billion people. In 2010, it was 6.9 billion. And by 2060, it is predicted to rise to nearly 10 billion people. A second key global risk factor is aging populations. Numbers of people aged over 60 are increasing, and especially in low and middle income countries. These two issues have huge implications for age-related blindness and for appropriate eye health service planning. Epidemiological data is used to select appropriate control measures for eye disease. Cataract and refractive errors are global diseases, as they occur across all populations and cause 75% of all avoidable visual impairment. There are clear treatment strategies for these two diseases, which can be implemented by strengthening eye health systems and ensuring access for all. Corneal blindness, trachoma and childhood blindness are considered focal diseases because they affect vulnerable high-risk groups of people. There are methods in place to identify endemic areas, to treat affected people, and more importantly, to implement appropriate prevention measures and strengthen primary eye care. Diabetic retinopathy and glaucoma fall into the chronic diseases category. Early detection and treatment is essential here to prevent blindness, and screening strategies are needed to find the patients as early as possible. Health systems also need to be prepared to appropriately manage cases identified by screening. To address these conditions, planning appropriate infrastructure for service delivery is a key priority, and implementing these control measures can avoid about 80% of visual impairment. Examining the magnitude of blindness in the context of person, place and time is essential to extract meaning from the numbers. It can also provide clues to the determinants of disease and for control options. In summary, it is essential to have clear case definitions for visual impairment and blindness, and to use these to obtain the numbers of people affected and to plan services. In this presentation, we have identified that the magnitude of global blindness is estimated to be 39 million people, that the distribution of visual impairment indicates that 90% of it is in low and middle income countries, and over 80% of blindness is in people aged 50 and above, and that women are more affected than men. Determinants of visual impairment and blindness vary across socio-economic groups and are closely linked with levels of poverty and the capacity of eye health systems. To control visual impairment, eye health systems must tailor services to specific needs as guided by local epidemiological data, and these should include the prevention of disease, strengthening accessibility and availability of surgical and optometry eye care services, and implementing strategies for early detection and management of chronic conditions.